This tablet is called as Viagra. Most of the males know when to use Viagra. Many males are using it for Viagra. But today, my dear friends, I would tell you a special use of this molecule. I'm not going to mention the brand name because I want to focus on the molecule, that is Sildenafil Citrate. Do you know this Sildenafil Citrate can also be used in females? It can be used in pregnancy. Today in this video, we'll discuss how this Viagra or this Sildenafil Citrate is used in pregnancy, when this Sildenafil Citrate is required for pregnancy, how to use it, why it should be used, what are the precautions which need to be taken, when it should be used. Good morning, I am Dr. Rajat and you have started watching our YouTube channel, The Fertility Gynecologist. First of all, what is this Sildenafil Citrate? Sildenafil Citrate is a 5-phosphodiesterase inhibitor. This phosphodiesterase is the enzyme which is responsible for the degradation of nitric oxide in the body. Nitric oxide is a vasodilator, and this enzyme is present especially on the maternal side of the placenta. Why do we require this nitric oxide and sildenafil citrate in pregnancy? There are two terminologies which are very important, which are very rampant. One is a fetal growth restriction and one is a preeclampsia. As I mentioned in my videos of heparin, there are two complications like gestational vascular complications. These gestational vascular complications are basically arising from the defective uteroplacental circulation or defective placentation, which leads to placental insufficiency. This placental insufficiency leads to the decrease in or suboptimal oxygen and nutrient delivery to the fetus, and thereby restricting the growth of fetus. Earlier we called this feature as IUGR, that is intrauterine growth retardation. Nowadays we call as fetal growth restriction. And second is preeclampsia. Preeclampsia, in which all the secondary things like proteinuria, blood pressure rise, all these things are in response to the release of hypoxic factors which are mediated by a placenta which is insufficient or a defective. So nowadays what we were taught is to treat preeclampsia and to treat fetal growth restriction. We used to treat the outcomes. If baby weight is less, then give some protein injection or give some protein sachets or protein tablets for increasing the birth weight of the baby. Or in fetal growth restriction or in severe preeclampsia, if the BP was raised, we give antihypertensive in form of labetalol, in form of nifedipine. But since they are placental disorders, they are caused by a defective placentation, if we directly focus on those uteroplacental circulation, then we can treat the root cause of fetal growth restriction and severe preeclampsia. Apart from prematurity, the major cause of neonatal morbidity and mortality is severe fetal growth restriction, which causes low birth weight, and as a result of the neonate suffers. By treating the placental cause, by treating the defective placental circulation, we can increase the duration of pregnancy, we can increase the blood supply to the fetus, we can increase the birth weight of the fetus, and thereby improving both the maternal and the neonatal outcomes. So what is the basis of using this sildenafil citrate or a Viagra in pregnancy? During pregnancy, nitric oxide increases. This nitric oxide, it causes the vascular adaptations in the body. What are these vascular adaptations? They reduce the maternal peripheral vascular resistance. They create a low resistance and a high caliber uteroplacental unit, which is needed to supply the adequate blood flow to the fetus. I am repeating the term: low resistance, high caliber uteroplacental circulation to provide the adequate blood flow to the baby. So nitric oxide is important in supplying, in ensuring that the maternal blood flow to the fetus, that means uteroplacental circulation, is good. In preeclampsia, like I said before, in and fetal growth restriction, there is a vasoactive substances are more, which leads to the vasoconstriction, and thereby the uteroplacental circulation is compromised. And since nitric oxide acts in dilating, in maintaining this adequate uteroplacental circulation, if we use some kind of a vasodilator, which is nitric oxide donor or prevents the degradation of nitric oxide, then the uteroplacental circulation can be improved. Like I said, placenta, fetal growth restriction and preeclampsia are pathologies in which Placental supply difficulties potentially lead to a disastrous complications in maternal and fetus, in both mother and fetus. So we have to improve the uteroplacental circulation. Because of this poor placental circulation, a poor perinatal outcome or a neonatal outcome and a poor maternal outcome is expected in pregnancies in whom there is a high vascular resistance. So the question is, I have told you the basis of fetal growth restriction and preeclampsia. The main pathology starts at about 8 to 9 weeks, at which time the placenta starts forming and development of placenta is complete by 12 to 13 weeks. So those are the important times during which the roots of pathogenesis of fetal growth restriction and the preeclampsia take place. We might know fetal growth restriction and preeclampsia at about 24, 26, 28 weeks of pregnancy, but the roots are there in the very, very, very early pregnancy. So this sildenafil citrate, it augments the blood flow, it augments the uteroplacental circulation, it ensures adequate supply of oxygen, adequate supply of nutrition from mother to the fetus. Because of this inadequate supply of nutrition and inadequate supply of oxygen, the fetal growth restrictions occur. And if this inadequate supply is maintained, then as a result there are hypoxic factors which are released in the body, and those hypoxic factors, they cause the severity of preeclampsia, like blood pressure rise, febrile edema, proteinuria, HELLP syndrome if it is severe. So we can prevent the occurrence of preeclampsia. If we are not able to prevent, we can mitigate the seriousness of preeclampsia, we can delay the preeclampsia, we can increase the gestational age of the fetus, we can increase the birth weight of the newborn, we can decrease the blood pressure, which can help us in prolonging the pregnancy, we can delay the complications of preeclampsia by augmenting the uteroplacental circulation. And for that, this molecule, my dear friends, sildenafil citrate, works wonders. Now, how do I know beforehand at 8 weeks, 9 weeks, 10 weeks that this patient is going to end up in fetal growth restriction and preeclampsia? Science has advanced. We have got a very, very, very good tool in a Doppler sonography. Apart from a good clinical history taking, and by good clinical history taking, I mean if there is a history of gestational vascular complications, past history. What are these gestational vascular complications? Past history of placenta previa, past history of abruption, past history of early pregnancy loss, which is in which there is no documented cause, past history of intrauterine fetal death, past history of stillbirth, past history of severe preeclampsia, past history of fetal growth restriction, past history of unexplained infertility or IVF conceived pregnancies. All these are factors which would suggest to me that there is a history of gestational vascular complications, and obstetrics, my dear friend, has a very funny habit of repeating itself. So this would give me an idea that this patient is likely to end up in gestational vascular complications, especially fetal growth restriction and preeclampsia. Now we do fetal anti-scan for every patient between 11 to 13 weeks. Apart from nuchal thickness, apart from ductus venosus flow, very, very important factor which we take is a uterine artery resist PI. Uterine artery PI. Uterine artery is the artery which supplies to the uterus from the myometrial vessels, it goes to the spiral vessels, then it goes to the placenta, and that is how it supplies the baby. So if there is an increase in uterine artery PI, if there is an increase in the resistance of the uterine artery, it would suggest to me that there is an increase in chance that as the pregnancy grows, later on this pregnancy might end up in fetal growth restriction or preeclampsia. So that gives me indication number one, that this is a high risk pregnancy and the risk of this pregnancy later on going into fetal growth restriction and preeclampsia is high. So how do I go about these things and how do I start this sildenafil citrate? When sildenafil citrate should be started in pregnancy, at what dose, and how it should be taken? I normally start sildenafil citrate in the dose of 25 to 50 milligram every day. It does not have to be taken orally. This tablet has not to be taken orally by mouth. Mind you, for patients, for males with erectile dysfunction, it is given 25 milligram orally by mouth, but in pregnancy, we do not give it by mouth. 25 to 50 milligram tablet, we ask the patient to keep it in the vagina at sleep time. It should be just kept near the cervix. So what we tell is take one tablet put it on the mouth of vagina and let it go inside and then sleep for half an hour. It should be as near to the cervix as possible, because near the cervix, 1 centimeter from the cervix, there is uterine artery, and we want this uterine artery to get dilated. By keeping this tablet local near to the cervix, local to the internal os, the uterine artery would start dilating, and as a result, the blood flow to the baby would increase. This tablet should be continued till about 30 to 32 weeks of pregnancy. This tablet, again, I told you, it does not have to be taken orally. It is absolutely essential that this needs to be kept in mind. What I have found with my patients when I asked to keep this tablet in vagina, most of the patients complain to me, sir, this tablet does not get dissolved. It comes out like same in the morning, but that is fine. This tablet keeps on doing its work. Apart from this tablet, for every patient of gestational vascular complication, especially in patients in whom fetal growth restriction and preeclampsia is suspected or expected, we start low dose aspirin 150 milligram for every patient. I have made a video on low dose aspirin. Please go and see it. For me, like I mentioned before in my aspirin video, I start low dose aspirin 150 milligram and each and every of my patient, because most of the patients have subclinical Apla syndrome. Some people may have past history of pregnancy loss which they don't tell us. In those cases, low dose aspirin improves the blood supply to the mother by decreasing the platelet aggregation. When my patients go to take aspirin from some other medical store, the medical store guy acts coyly and tells the patient that this is a blood thinner tablet and tell your doctor that you do not need this tablet. I am a doctor. I have studied gynec for almost 20 years now, and I know what I am doing. This is not a blood thinner tablet. First of all, we tell that this is a blood thinner so that the patients can understand it better. Aspirin prevents the aggregation of platelet. Thereby, it prevents the formation of thrombi. Microthrombi, if they are formed, they go and get deposited in the very minute micro vessels, especially the spiral arterioles, the small myometrial vessels, and they decrease or stop the blood flow from mother to the uterus, from uterus to the baby, and as a result, the pregnancy loss can occur, preeclampsia can occur, fetal growth restriction can occur. So, I normally start ecosprin 150 milligram, low dose aspirin 150 milligram, and each and every of my patient the moment pregnancy is diagnosed. Fetal Medicine Foundation also recommends to start 150 milligram aspirin at 12 weeks of pregnancy if the uterine artery resistance is high. Now there are two things: you measure right uterine artery and you measure left uterine artery. You calculate the mean of uterine artery, and if mean of uterine artery is high, then you start ecosprin. There are different values available of the uterine artery PI at different weeks of pregnancy. We can refer to them and then start ecosprin. But like I said, it is better to start because ecosprin in pregnancy almost has zero side effects, and the good effects of ecosprin, they far outweigh the possible side effects of ecosprin which might be there. I haven't seen, to be very frankly. This uses of sildenafil, it increases the birth weight of fetus by about 10%. It increases the abdominal circumference and thereby the expected fetal weight by about 10%. By mechanism of improving the blood flow to the uterus and thereby uterus to the placenta, it also improves the amniotic fluid index. It improves the oligohydramnios also in the fetus. In few cases, at about 24 weeks, there are vascular Doppler changes in the fetus in which suggests that there is an increase in uterine artery resistance, possible alteration in the umbilical artery flow, increase high resistance umbilical artery flow, and the fetal weight is very less, somewhat about 300 to 400 grams. Many doctors who do not know how to interpret a Doppler, they advise termination of pregnancy in those cases. We take a different route. Uterine artery resistance is high, as a result the umbilical artery resistance is high, and if the umbilical resistance is high for a period of time, 10 days, 2 weeks, 3 weeks, then the adaptive vascular changes in the fetal vein would start occurring. There would be a compensatory vasodilatation of the middle cerebral artery. If patient directly comes to me at 24 weeks with this kind of report, I do 3 things in my patient. A, I counsel the patient that this case can be salvaged. B, I start Sildenafil Citrate 50 to 100 milligram vaginally per day. I also give L-arginine. L-arginine is a nitric oxide donor. So it increases the nitric oxide in the body, which causes a generalized vasodilatation of the maternal system, and as a result the uteroplacental circulation improves. Sildenafil Citrate would prevent the degradation of nitric oxide. So they both act synergistically. L-arginine is also an amino acid which would help in building the increasing the fetal weight. Apart from that, like I mentioned in my LMWH video, if there is a high-risk pregnancy, precious pregnancy, IVF conceived pregnancy, multiple IVF failure patients, I start LMWH, low molecular weight heparin in such patients. And I also give amniotic amino acid infusion every weekly to such patients for increasing the fetal weight. These 4 modalities, apart from in high protein diet in form of biscuits, protein tablets or amino acid tablets, it gives me a grace period for 8 to 10 weeks. I am able to pull on the pregnancy till 30, 32, 34 weeks. By pulling on the pregnancy and by improving the uteroplacental circulation, I am able to increase the birth weight of the fetus. If I don't do all such modalities or any of such modalities, then that 24-week pregnancy which patient came to me, by 26, 27 or 28 weeks, it would have ended up in severe preeclampsia. The blood pressure would have shot up. The liquor may have gone severe oligohydramnios. Doppler changes may have worsened. There may have been a fetal change, the changes in fetal MCA. And the baby's weight would have been only 300 to 400 grams. And the only treatment of preeclampsia or severe fetal growth restriction is to get a live baby out, because if that baby is inside, then there are chances that baby may die anyway. By taking the baby out, we may have some sort of survival. But 400 gram baby at 28 weeks compared to 32 weeks pregnancy, and that 400 gram to 1000 gram, the chances of survival of the baby increase manifold. So, like I said, these 4 modalities, low dose aspirin, Sildenafil Citrate, low molecular weight heparin, and amino acid infusions, they have worked. They are my absolute great tools in management, prevention, delaying, mitigation of complications of severe preeclampsia. Sildenafil citrate, various studies have been conducted. It alters and it normalizes the abnormal Doppler patterns in such patients. It has shown to normalize the umbilical artery resistance. It has shown to normalize the uterine artery resistance. There is a stridal trial which is going on. Stridal trial is Sildenafil therapy in dismal prognosis of early onset fetal growth restriction, STRIDOR. It is a first prospective, large, randomized, multi-central trials which is going on at various places. And over a period of time, after some years, we would get to know the advantages of or disadvantages of use of Sildenafil in pregnancy. Very, very, very few patients, if I continue this, what I do is I continue this Sildenafil till 30-31 weeks, and after that, if the pregnancy is prolonging, if patient therapy is costly to the patient, I switch over from Sildenafil to L-arginine. A, delivery can be conducted at any point of time. B, in very, very few patients, what I have found out is Sildenafil possibly causes some respiratory alterations, some PPHN in newborn, and as a result, the NICU requirement is there. But anyway, if I have to do a delivery at 30-31 weeks, baby weight would be less, the maturity would be less. Anyway, the baby would require a NICU management. But the chances of ventilation would be less, the requirement of oxygenation would be less, the NICU stay would be less, and overall the expenditure of the patients or the prospective parents would be less, and the chances of having a THBR, take home baby rate, would increase manifold if I do these kinds of interventions in my patients. I am a gynecologist. The difference between a gynecologist and a DIAN is, DIAN tells the patients to go to a doctor when the complication occurs. We in gynecology have been taught to A, anticipate the complication, B, prevent the complication. If we are not able to prevent the complication, delay the complication. And if we are not able to delay the complication, we try to mitigate or decrease the disastrous impact of the complication. And this is what I do in each and every of my patients. Anticipation is by a good clinical history, good clinical examination, and a good Doppler. For me, any patient of an NT scan which does not have a uterine artery Doppler, that is a useless NT scan report. It has to mention the uterine artery Doppler, uterine artery PI report, the mean uterine artery PI, and the values at the specific weeks. What are the values? Because percentile is important. What is the 5th percentile of that uterine artery PI at that particular week? What is the 95th percentile of uterine artery PI at that particular week? That is very, very important. If I know at 12 weeks that there is an increase in uterine artery resistance, I can start all these interventions which would possibly prevent the chances of severe preeclampsia and fetal growth restriction. My aim as a gynecologist is to give a good baby to the parents. The maternal complications should not be there. And I want them to be happy. I want them to carry a good baby. I do not want them to cry if an IUFD occurs at 26 weeks, 27 weeks, or there is a severe hypertension, severe preeclampsia at 26, 28 weeks, and I have to, because the treatment of severe preeclampsia is to do a delivery, to save the life of the mother. Baby, we forget at that point of time. So I want to give a good baby, and mother should also be healthy. Albeit in such cases, the baby weight would be less. It would not be 2.5 kg. It may be 1.6 kg, 1.7 kg, even 1.2 kg is fine. It may require 5 days, 7 days, 10 days NICU requirement. That is okay. So this was about, many patients talk to me, sir, why you are giving this Sildenafil? So I thought of making this video. This was a beautiful video about use of Sildenafil Citrate in pregnancy. If you have any questions, please comment. Please like the video, share the video, and please subscribe to our channel. Namaskar. Bye-bye.